Greetings and hello from this side of the world of India to all my seniors, all my colleagues, and all the medical students who will be watching this particular video. I'm Dr. Madhukar Shinde, and I'm working as an associate professor in one of the medical colleges and universities in India, in one of a small, tiny city, Pune. In this video where I've been asked to present my 20 years work in 20 minutes unfortunately, but I'll try my best to do a fair justice on the work which I've been doing since last 15 to 20 years. The work I've been doing is program labor compared with expected management. Is it truly a need of a new millennium? By doing this particular video presentation at the end of the video, I hope the carry home message will be very clear to all of you, which I'll be mentioning at the end. Well, this is the place where my work was carried out. As I said before, a small city in India named Pune, which is at the western side of India. The name of the college is Bharati Vidyapit Medical College and Deemed University. Well, I'll also be mentioning about DY Patil Medical College and Deemed University, where I'm presently working. In the background, I would just like to brief you on this particular work, what really actually inspired me to do this. Well, mechanism triggering the initiation of human parturition is still an enigma. At term, a series of complex physiological, biochemical, and physical processes cascade, resulting in a delivery of the fetus. This study deals exclusively with comparison of normal labor, induction of labor with prostaglandins, and augmentation by intracervical insertion of PGE2 tablets, amniotomy, which we commonly call as artificial rupture of membranes, and smooth muscle relaxant drugs. Advantage and disadvantages of each of the above methods are compared with expected management of labor. Aim of the study was to compare pros and cons of program labor to that with the expected management. Well, in this jet age, I would say when everything is so much programmed, then why not a planned delivery when everything is so planned in our duly really life and in the 21st century? By this, what I mean to say is that in this jet age, delivery is to be conducted in a well organized and streamlined fashion, ensuring rapid delivery with reduced maternal and fetal stress. Well, and the objective being, is it a worthwhile therapeutic option when the benefits to either the mother or fetus outweighs those of the expectant management? Well, these are the places which truly taught me and not only grew me up as a different, altogether different human being. Well, I should not say taught me, but I'm still learning. To begin with, the Harvard University, Boston, where I worked good numbers of years in research. What research really taught me was the power to treat millions of patients in one go. What I mean to say by this is, by medical treatment, you can treat one patient at a time. But with research, you're going to do the fair deal with millions of patients, and the patient gets the benefit of it. Coming to Europe, CORK University Maternity Hospital, which was the second home, one of the best hospitals for gynae in the whole world, I would say, where they are pioneers of all the guidelines and instructions. Well, but from Europe, I never learned any kind of high technology, but Europe really taught me how to be a safe doctor, how to do a safe practice. Coming lastly to Africa, well, this was again a different experience altogether, wherein I worked in endemic areas of Africa, and it really was an eye opener to see how women's services differ from country to country in endemic areas. The source was this particular medical college where I'm talking about, but it also had few other outreach clinics and small primary health centers attached to this hospital, where I cannot deny or ignore these particular small setups wherein we got so many patients coming there. Even if the total number of deliveries was quite high, the unit was very busy. We still tried to shell out 100 pregnant full-term patients and took them into our study. 100 cases were control and 100 cases were program labor. Well, the inclusion criteria is very straightforward, I would say, as throughout my whole study, one thing which I have been carefully looked after is the safety of the patient. Wherein, in inclusion criteria, I have taken all term patients who have crossed 37, 38 weeks of gestation, but of course, they have not crossed the line of postnatal at all. All the parameters of obstetrics fall within normal range, right from obstetrical examination of the lie, presentation, adequacy of the pelvis, and all the patients, of course, are very ready to participate in the study. Well, the exclusion criteria is also pretty straightforward, I would say. Similar basis of inclusion criteria, exclusion criteria again determine the safety of the patient is 100%. I have excluded all the patients which are relatively contraindicated and absolute contraindication, right? Starting from the adequacy of pelvis, no comorbidities of patients are present anywhere, right from IVF to medical and surgical complications. Well, the participants are again based on what I said about the inclusion and exclusion criteria. These 100 pregnant patients, which are full term, I've excluded all the comorbidities which are associated with pregnancy. Straightforward, full term pregnant patients which have no complication, either medical, surgical, or obstetrical. Control cases are on the similar basis. Well, in program labor, I think counseling forms a really very important part, or rather, I would say in this whole study, what really took my whole energy out of me was the counseling part. It's very, very difficult, in developing countries or underdeveloped countries to really counsel the patient about this particular study because obvious reasons the mother is first worried about her safety and her baby's safety. But still, I think we were succeeded in counseling so many patients there. Verbal consent was again very important because it was very difficult to give a piece of paper to the patient and asking her to sign it right away. But yes, a written consent was performed. Coming to the methodology, at 0 hours, a tablet primary process with PGE to alpha was kept. It was repeated 3 hourly, and a total dose of 3 tablets were given. Obviously, all the patients were monitored in the control group or program group parthographically very, very meticulously. Coming to artificial rupture of membrane, of course, what I believe is rupturing membrane at a very early stage, like for example, taking 2 to 3 centimeters, I would say patient somehow goes into dry labor, and once she's fully dilated, it becomes very, very difficult for the baby's head to rotate because I think always the liquor acts as a lubricant for the baby's head to rotate. I always tell the medical student about this. So I guess 4 to 5 centimeters is quite a safe dilatation or the period I would say where we can safely do amniotomy, rupture the membrane, and that would add drastically to the augmentation of labor. Here at this point, I would really say people have different schools of thought regarding ARM in regards to effacement of the cervix. What I would say, what we observed in our study, patient who had a very effaced, thinned out cervix at 4 to 5 centimeter gives you excellent results. On the other hand, with a thick cervix where the Bishop score is really very poor, well, we would really say difficult for it to progress depending again of course on the contractions of the uterus. Buscopan is one of the muscle relaxant which would I say quite an assistant role but definitely not a major role in augmenting the labor. But again here I would say a cervix which has been effaced very beautifully is going to respond to smooth muscle relaxant also in a beautiful way. Controlled groups, we've taken all the patients into latent phase and monitored them meticulously only with the help of cartogram. No kind of interventions was done at all. Okay, now results. What I'll be talking about is factors which I looked at study group and control group. Well, this was, I would say, the final outcome where induction delivery forms the mainstay. That is what we really want to really come at the conclusion. We are not trying to prove anything out here. We are just trying to see what is the safest method, what is the most convenient method, what the patient or the mother and baby could get out of this particular study. So induction delivery interval, I would say, is one of the best criteria to look for. Secondly, of course, any medical complication, surgical complication, or any medication which was used apart from the protocol was also be mentioned on the case sheets and case files. Any operative intervention, of course, was mentioned, and those patients were not included in the study, as I had said in the beginning of the video presentation. Of course, the maternal and neonatal clinical outcome forms the mainstay of the whole study. Similarly, in control groups, same duration was taken, duration of labor, complication, either medical, surgical, and the maternal and neonatal clinical outcome. Well, coming to the age parameter, which is one of the first one in the study to look for. In the study, we observed that majority of the patients fell into the age group of 21 and 25 years of age. The youngest one being the age of 17 years and the eldest being that of age of 29 years. In this, we observe that primary gravidas and second gravida patients require 2 tablets each in latent phase, one tablet in active phase. All primary gravidas require the set of total doses of injection Buscopan, which is a smooth muscle relaxant, a total dose of 3, while the fourth gravida required only one injection Buscopan, that is a smooth muscle relaxant. Well, what I really wanted to show here about the age factor and of course the tablet factor in terms of gravida is primary gravida for all obvious reasons will be requiring more number of tablets in the latent phase, which I have observed. Coming to the active phase, where already the cervical effacement have taken place in a very beautiful manner, believe me, the tablet number of prostaglandins required was definitely less. Coming to multigravidas, the most specific point being in the latent phase itself, the number of tablets were required less, as the cervical consistency, which forms the mainstay of the study or major factor determining the progress of the labor, always required less progress, less prostaglandins in a multigravida compared to a primary gravida. कोई induction ये बना है average. Well, coming to the duration of labor, the average duration of latent phase in primary gravida of control group was 13 hours, while of fourth gravida was 5 hours. The average duration of active phase of labor in a primary gravida was 9 hours, and that of fourth gravida was 5 hours. Thus, the total duration of labor, including the latent and active phase in a primary gravida, constituted about 22 hours, and that of fourth gravida was 10 hours. It was also observed that induction delivery intervals in a primary gravida was observed to be an average of 9 hours, while in second gravida was 6.5 hours, in third gravida 5.5 hours, and fourth gravida 4 hours. Well, coming to the intervention, I really won't say medical and operative intervention, but it's the intervention which are required during the whole process of this induction of labor, both in control group and study group. In the study part of study 1, patient from the study group required oxytocin from study group and 4 cases from the control group due to hypotonia of the uterus. Ventouse was required for 6 cases of control group due to prolonged second stage. Emergency lower segment cesarean section was required in study group due to hypertonic uterine contraction with fetal distress. Well, coming to this part where analyzed after all the studies, it required a really lot of patience in this particular case. Results were stratified by parity and the clinical variables of maternal and gestational age assessed. Lower cesarean delivery rate was 8% for multiparous women, less than 30 years who delivered at 39 weeks of gestation. The relative risk of cesarean delivery increased from women of 30 to 34 years and was highest among women 40 years and older regardless of the parity. The frequency of cesarean delivery was significantly lower in the induction group than in the expectant managing group. Well, coming to this particular outcome of timing of delivery, for nullipary induced by BRD, starting the induction in the evening instead of during the daytime may reduce the number of nighttime deliveries substantially. Where here I would really like to mention a small reference from stud volume 16, wherein research was carried out in Dublin on a very large scale, a very beautiful research where I would like all, especially the medical student and my juniors, to really look into this particular matter, and that will significantly highlight the particular intentions of this particular research study. In Dublin, when the researches were carried out, regarding the lifespan of doctors compared to the stress that is given by that particular specialty, Second thing is about the maximum neonatal deaths, which were really studied all throughout the world. What these people find out during the research study over gazillion number of years was that maximum neonatal deliveries, or even I would say maternal deaths, were caused during this night hours from 2 a.m. to 6 a.m. Now, why this was so? This was so because, according to scientific researches and studies, the human threshold of the blood is at the lowest peak between this particular time. And now, when compared to these particular deaths, which were taken place during this particular period only, so I would say this is really one of the most significant point, or rather I would say one of the carry home messages for everyone to consider this particular study in a very different perspective point of view. So by doing this particular delivery in the daytime where all the resources are at reach, the maximum threshold of the brain is at the highest working level, definitely we could deliver these mothers and these lovely children in a very, very nice outcome way, I would say. Well, here I've tried my best in fairness to give the outcomes, whether it may be surgical or it may be unavoidable or outcomes which are really not pleasant for the patient and for the babies. Well, coming in the study group, one patient had to undergo emergency cesarean section due to adverse effects of the dinoprostone, prostaglandins, relating to hypertonic uterine contraction leading to fetal distress. One had mild PPH due to atonia of the uterus, could be due to effect of prostaglandins, where I've observed in many, many cases. Some of needed oxytocin drip in second stage of labor due to uterine hypotonia. One patient had a precipitate labor attributed to dinoprostone, which deteriorated into third degree TED. Well, yes, I will be considering all these into morbidity of the patient. Coming to the control group, fortunately, there was no such surgical interventions required, but six patients had venous delivery, which were due to maternal exhaustion in second stage labor, leading to poor bearing down efforts. Here, I would like to mention this is the part where active manual labor comes into place. This is the part where augmentation comes into role. Had it been we would have augmented this patient according to the protocol, there wouldn't have been maternal exhaustion. Timely interventions would have been taken and there would have been safe delivery of the mother and would have definitely given a better outcome of the neonatal. Three patients had mild to moderate postpartum hemorrhage. Three patients required oxytocin drip in second stage due to poor bearing down efforts and maternal exhaustion. All were due to obvious reasons, what I was saying. Well, the neonatal outcome, I would say all newborn babies had a good UPGAR score in both study and the control group, as these were the only patients which were taken into consideration as study where exclusion of all the comorbidities were done. Thus, the study group could not prove any upper hand in the neonatal outcome. Now, this is a very important statement. The study group could not prove any upper hand in the neonatal outcome. So there, here again, I would really like to focus or refer to my previous study, which I was talking about, the study volume 16, where large researches were carried out in Dublin regarding the peak time of the night, where the human brain threshold was at the lowest level, and maximum neonatal deaths were taking place during that particular time. So again, I want to really impart, or again, I want to focus on this particular point of induction of labor. Let it be unindicated induction of labor, but considering these elective indication or planned labor would definitely give the benefit to the mother and babies by doing this conducting of delivery during daytime where all the resources are at reach and maximum manpower can be given to the mother and the baby, and the brain threshold of the human is at highest level. These all will contribute to the 100% safety of the mother and the baby. Well, coming to this concluding part, well, I'll divide it in two parts. One is a good part where everyone would like to hear, and one is a bad part where I wouldn't say everyone would like to hear, but I would leave you all the audience with a strong thinking point. Coming to this now, by benefits of program labor is the patient gets the benefit of decrease in duration of labor. Protocol can be followed for the convenience of doctor and as per the convenience and requirement of the patient. Getting delivered during office timings can get the benefit of getting delivered with full efficiency of the obstetrician is maximum and all the resources are at reach. Now, coming this part, but is it worth giving a logical thought? This decrease in duration of labor is at the cost of how many significant hours? And is it worth getting the benefit at the cost of unnecessary expenditure, taking the socio-economic status into consideration? Thus, to conclude, program labor does not have any upper hand over expectant management. It is definitely not a worthwhile therapeutic option to ensure rapid delivery in a streamlined fashion to just save few hours and for the convenience sake at the cost of operative interference and unnecessary expenditure that should be practiced only in an indicated and selected patients, especially taking women's positive approach towards elective induction. So, my dear audience, my friends, my respected seniors, especially the young buds who are getting graduated and going to go in the field of obstetrics and gynecology, I would very humbly, very kindly give one carry home message is that either you do a unindicated induction of labor for the convenience of the doctor, or you do a pure elective induction of the patient during office hours to give maximum benefit to the patient, to the mother and the child. But one carry home message remains that patient safety remains priority at all time. If at all I have to talk for number of hours on this particular topic, the only concluding statement would be patient safety is the priority at all times. Thank you so much everyone for this patient hearing. Have a good day. Thank you so much.